So our second speaker is Dr. Fred Semitala, which is also well known to everybody. Fred is an infectious diseases specialist with a special interest in implementation science at Makerere University, where he's also the principal investigator for the Makerere University STRIPE. And they have piloted a STRIPE course on an LMS, and he will share his experience with us. Thank you, Fred. We can see your slides, but we're not hearing you yet.
Oh, my apologies. So thank you, Mariki, for having me to present our experience to this very important meeting. I must say that I have one or two of my colleagues who have joined me, and hopefully they will be able to make some responses to some of the questions as they arise. So our program is titled Education for Interprofessional HIV Care in Uganda. And here is the outline of the brief presentation that I intend to make in the next few minutes. So like Cheyenne has mentioned, our initial means of training was face-to-face. But due to COVID-related restrictions, we quickly embarked on a process to transition the training to some kind of blended methods of learning. And largely, it was online with a few face-to-face training sessions. So to do this, we adopted the LMS, which has been in use by some of the schools at the university. But for many of us, it was a new experience. So in terms of processes that went through to set this up, right from the time of conceptualizing this transition, we engaged e-learning experts and the IT experts within the university. We also worked very closely with the guideline content and script writers from the Uganda AIDS Control Program. And fortunately for us, the guidelines had just been revised or updated in February, just before the pandemic broke out. And so we had a one-day physical workshop to review the modules that had been assigned to us, as indicated on the slides. But briefly, Module 9 looked at ART adherence and evaluation of biologic failure. Module 10 looked at end of life. And Module 11 was looking at pre-exposure prophylaxis and care for men who have sex with men. And Module 13 was talking about the health system building blocks. So at that meeting, before that meeting, we assigned module leaders. We had assigned module leaders who made initial presentations and received feedback on how they thought the module would be. And then we, along the way, developed interactive video technology for facilitating interprofessional education and practice. We also had face-to-face training of trainers, workshops at the Mulago ISS clinic. So what I didn't say is that we've had 4 collaborating institutions, and each in our initial and 2 was to break down the materials to small content. And then they were also supposed to work with the LMS and IT experts to develop a roadmap for delivery of the materials to the learners. So that picture is one that we took after our initial meeting, integrated meeting with the ICT team, with the LMS experts, and then the facilitators and some preceptors who are going to actually do the training. And this other picture shows one of the schools which had had a face-to-face interaction with the IT and LMS expert, while their course module leaders were facilitating using online means. And the idea was that the trainers then would have a hands-on experience in the room, while the leaders who had already had that training would facilitate via online means. So in terms of the tools we deployed for the training, we deployed a well-contextualized online curriculum, as I've mentioned, related to the guidelines. And at that time, we already had access to Zoom with the Zoom room function, which enabled group discussion sessions and also interprofessional mixed discussions. We developed a mobile application support to support easy accessibility of learning the content. And also this allowed for offline access, especially in areas where there was limited internet connectivity. In terms of the quality improvement, which is a core part of this training, this was tracked during group assignments that involved identifying gaps at their workstations. And validation checks were included in the LMS to ensure completeness of the entire course. So to do this, we procured some equipment that would enable us to centrally be able to do facilitation of the training, the online training. And in that picture, we are receiving the equipment, the video learning equipment at our Center of Excellence, our HIV Center of Excellence in Mulago. So I just thought that we would share some visual interface, and what this one shows here is the home page for the program. And maybe what I can say here, I don't know how much you can see, but the point to make here is that this was accessed online via a web address, and the address is highlighted there. And also that the user accounts were created by the system administrator for each user. And that included the people who provided support, the learners, as well as the facilitators. This is, for example, one of our participating institutions, and this is how their Module 13 looked like. And you can see that in addition to decentralizing the platform by institution, we also included a chat room for each module and reference materials which were included, and for example, the guidelines. And then we also had a clear structure of the course, the roadmap for the module. So in terms of monitoring and evaluation, and I should be finishing soon, we conducted an online baseline assessment with the facilitators and noted that 34% had some experience in online teaching, but they had high limitations in ICT infrastructure, interactive simulations, and online mentorship. We conducted pre and post assessments via the LMS for each of the modules and integrated a section on course evaluation feedback and online certificates. So in a way, the students were motivated because they could do everything by themselves. We also had an end-line qualitative interview conducted to capture experiences and the perceptions of the learners. So we had some lessons that we learned from this program. Of course, earlier engagement of key national stakeholders such as MOH, training hospitals, and the universities made it easy to launch and implement this kind of blended learning. So inclusion of preceptors as facilitators provided opportunity for learners to get physical support, some learners to get physical support at their workstations, even during this largely online training. And also mixing of more experienced with recently qualified providers facilitated effective peer learning in and outside of the general class kind of training. And group assignments exposed the learners to quality improvement approaches for problem solving. We also learned some challenges that reliable internet would be critical for successful e-learning, and platforms that can support working offline, which would alleviate that major barrier. We also learned that use of training approaches that minimize the requirement for all learners to be online at the same time would improve uptake and completion due to competing priorities. For example, nearly 25% of the learners who completed our training did so after the scheduled period, and so they had time to pace themselves and completed at the end. Thank you very much for listening to me, and I hope you to hear some feedback.
Thank you, Fred. That was very interesting, very innovative. I must congratulate you and your team. And thank you also to Shadrach, who has been answering questions on the chat room already. Thank you so much.